Have you ever heard of the word amyloidosis?
Amylose.
Come si chiama? Amyloidosi.
Ay, no.
¿Les suena de algo la amiloidosis?
No.
Say it again.
Amyloidosi.
Amyloidose.
C'est un drôle de nom.
Nunca é uma palavra muito complicada.
Amyloidos, nej.
Eu nunca tinha ouvido falar.
Un dessert peut-être.
Amyloid, det är någon blomma.
C'est musica.
Amyloidosis, sí, en Doctor House lo escuché.
Una malattia.
Is it a disease?
Suena como una enfermedad. Has entrevistado a dos que estaban en una edad que tenemos todos los caporos los papeles hechos.
Très bien, oui, qu'on en parle un peu plus.
Vou pesquisar, vou me informar sim, com certeza.
Je vais dire ça à mon médecin, moi. Ça m'intéresse de savoir.
So what is it exactly?
C'est une pathologie avec un dépôt de
Une accumulation de protéines.
partout dans les vaisseaux.
Brother-in-law, he developed cardiac amyloidosis.
Si on n'avait pas dépisté chez ma grand-mère, on n'aurait jamais su.
Estudio medicina actualmente en la escuela de medicina aquí en la facultad, pero desconozco del tema, casi no lo había escuchado.
Mesdames et messieurs, bonjour à tous, señores y señoras. Bienvenidos, señores, señori, benvenuti. And last but not least, ladies and gentlemen, welcome to our special roundtable for the second edition of the World Amyloidosis Day. Amyloidosis. You may be familiar with this name, but like we've seen in the street interviews, most of the population isn't. This is the reason why the Amyloidosis Alliance, alongside the worldwide patient organizations, have created an International Day of Awareness dedicated to amyloidosis, this rare disease with 18 participating countries around the world. Today we will help you understand better what amyloidosis is and how it affects the life of patients. Throughout this roundtable, we will also, thanks to our doctors, specialists in the field and our patient representatives, dive into the following topics: suspicion, symptoms, red flags and diagnosis, treatments and medical research, and finally we will focus on the people and organizations supporting patients living with the disease. This roundtable is organized by the Amyloidosis Alliance, an umbrella organization covering national and local patient associations. But first of all, please welcome the Amyloidosis Alliance board members with a short introduction.
Bonjour, je suis Jean-Christophe Fidalgo et je suis le président de l'Alliance Amyleuse. Il s'agit d'une organisation internationale qui regroupe des associations de patients dans le monde entier. Nous avons créé en 2021 la première journée mondiale de l'amylose. Je suis ici aujourd'hui avec mes amis, les membres du bureau de l'Alliance, pour vous présenter la seconde édition et qui, comme toutes les journées à venir, se déroulera le 26 octobre.
Lo scopo di questa giornata è quello di informare il pubblico su questa malattia rara. Pertanto non è rivolta soltanto agli specialisti, ma soprattutto ai medici di famiglia. Sono le persone presso cui il paziente si rivolge manifestando loro i propri sintomi. Inoltre occorre considerare che la malattia impatta sulla vita giornaliera del paziente e delle persone che vivono accanto a lui.
En realidad, amiloidosis es una palabra genérica que engloba un conjunto de enfermedades diferentes entre ellas y que además tienen diferentes abordajes y tratamientos. Lo que sí tienen en común este grupo de enfermedades es que es vital empezar con el tratamiento lo más pronto posible.
Amyloidosis is a very complex disease. There are many symptoms. Those symptoms are really difficult to put together, but there are many red flags that we hope that doctors will pick up and put the jigsaw together and come up with a diagnosis that is much quicker than it used to be years ago. We used to have the disease take 4 to 7 years to diagnose. Putting the symptoms together will make that much quicker situation. Symptoms include the heart issues, it includes peripheral neuropathy with your hands and feet, gastro problems, weight loss, to name but a few. So the biggest positive part of this disease is also that there's some good new treatments available that weren't even there 2 years ago.
Join the World Amyloidosis Day, and for more information, contact your local organization. Thank you.
Thank you very much. Thank you and hello to all of you for being here with me in Paris. You know, this roundtable will be part of the second edition, as we've seen in the video, of the World Amyloidosis Day. So you're all either doctors or organization patient representatives. And what I'd like, if you don't mind, please, that you say a few words about you. So we introduce yourselves a little bit, and you tell us what is your link to this disease and why you're here today. Maybe you want to start with you, Jean-Christophe.
Hello, I'm Jean-Christophe Fidalgo. I'm a patient with hereditary form, and I'm part of the French Association and one of the founders of the Amyloidosis Alliance.
Thank you, Jean-Christophe. Sophie.
Hello, everybody. So I am a professor of internal medicine and clinical immunology in Paris, France, and I am leading the reference center here in France for AA amyloidosis.
Thank you.
I'm Catilena from Spain, and I am a patient. I live with hATTR amyloidosis, and I represent the Asociación Balear de la Enfermedad de Andrade.
Gracias.
I'm Barbara from the French patient support group, and I'm a patient with AL amyloidosis, heart and kidney involvement.
Hi there, I'm Vince Nicholas. I represent the UK ATTR Amyloidosis Patient Association. I am also a patient with hereditary amyloidosis.
Thank you.
Hi, my name's Paul Pozzo. I represent also the UK Amyloidosis Patients Association. I have wild type amyloidosis.
My name is Andoni Echanit-Lagun. I'm a neurologist here in Paris, and I'm working at the referral center for TTR amyloidosis.
And my name is Julian Gilmore, and I'm Professor of Medicine at the Amyloidosis Centre in London, National Amyloidosis Centre, and I've been working and specialising in amyloidosis for around 25 years now and researching it.
Thank you very much to all of you for introducing yourselves. We're going to start with the first question, as some people might wonder. We've seen in this street interviews that most people from the public don't know what this is. So maybe, Andoni, we're going to start with you. Can you tell us in a few words what is amyloidosis?
Thank you, Marco. So amyloidosis really is a constellation of different disorders that basically have a common point, that is the accumulation of an abnormal protein on tissues. And this accumulation can happen in heart, it can happen in peripheral nerve, it can happen in the kidney. And amyloidosis is a very rare disorder. It's not as frequent as breast cancer or diabetes. And unfortunately, symptoms are quite not specific, and patients can present with very diverse symptoms, and diagnosis is usually quite difficult to make. So that's basically the story of amyloidosis. There are more than 30 subtypes of amyloidosis, but I guess we're going to speak about the majority of them.
Absolutely.
Today.
Thank you very much. Julian, are you live from the UK, right, with us?
I am indeed, yeah.
Thank you for being with us. Do you mind maybe saying a few words as well on what is your story on what amyloidosis is?
Yes, I agree with what you've already heard. It's essentially a disorder of protein. You know, proteins are the building blocks of the body, and we've got thousands of proteins in our body, and normally the body makes them and gets rid of them in equilibrium. And you know, when you develop amyloid, a particular protein in the body, if you like, misfolds and becomes what we call insoluble. In other words, it becomes a little bit sticky, if you like, and the body can't really break it down very easily. And so that protein, that sticky protein, deposits in certain organs in the body, and as you've heard, it can affect pretty much any organ in the body. Deposit in those organs and damages the function of those organs. And as you've heard again, there are many, many different types of amyloid, and they are based on which protein it is that's misfolding and depositing. So in one type of amyloid, it's one protein that misfolds and deposits in an organ, and in a different type of amyloid, it's a different protein that misfolds and deposits in the organ.
Thank you very much. So if my understanding is correct, it's not one disease, it's a group of different diseases, right?
That's exactly this. That's really a group of different disorders, and they are classified on the basis of which protein is accumulating.
Do any of you has any numbers? Maybe you want to talk about the numbers. How many people in the world maybe are affected by this disease? And
maybe I can answer for France, and maybe Julian could after answer for the UK. So we estimate in France about 200,000 of patients with cardiac amyloidosis, especially wild type TTR, and we estimate about 500 to 700 new cases of AL amyloidosis in France. And then we estimate about 800 of patients in France with AA or genetic TTR amyloidosis nowadays.
Thank you, Sophie.
As Sophie said, we estimate, and I think the truth is that we really don't know the prevalence because we know that it probably gets missed, the diagnosis gets missed. There are probably certain types of amyloidosis where the diagnosis is missed more frequently than others. And the honest truth, I think, is that we really don't know the prevalence of this condition. A good example is that, it wasn't so long ago that we thought one particular type of amyloid, ATTR amyloidosis, was a very rare disease. And we now think that it's not an uncommon cause of heart failure in elderly, usually male individuals. Sophie mentioned wild type ATTR amyloidosis, and we now think that that's probably not such a rare disease at all. And that's really because it's being diagnosed, whereas it wasn't being diagnosed previously. So I think the prevalence and how common this disease is really not terribly well known. I think it's not a common disease, but on the other hand, it may be less rare than we previously thought.
Thank you, Julian. So we're going to start now with the first part of this roundtable. We're going to talk about suspicion and diagnosis. So that's a perfect transition from Julian. Sophie, as a doctor, can you tell us how it's diagnosed? So we've seen that it's difficult to diagnose, and what are the first signs or red flags that can alert the people that can have this?
So the diagnosis of amyloidosis relies on the examination of a tissue by the microscope. So it usually means that you need to get a biopsy of a tissue. So mostly it's like skin or digestive tract or kidney, or more rarely heart. And then a doctor, a specialist, a pathologist looks for the amyloid plaque, which is the signature of the amyloidosis process. And then he has to type which protein is mainly in the plaque, in the deposits. But for the newly diagnosed type of amyloidosis that Julian just spoke about, the TTR1, a biopsy may not be always necessary.
Yeah, perhaps we need to add that in the genetic forms, to have the final diagnosis, you need to obtain a gene analysis. You have the deposits, but you need also the gene analysis.
Thank you very much. Yes, Julian, please.
I was just going to add to what Sophie said in terms of the amyloid being a biopsy diagnosis, precisely as she says. On top of that, the histopathology doctor needs to specifically stain for amyloid with a particular stain, and that can be a challenge. Unless they actually stain the tissue with a particular stain known as Congo red, then they won't necessarily see amyloid. So sometimes you can have a biopsy and the particular stain isn't done, so the diagnosis is missed on that basis.
Thank you very much, Julian. And to have a cardiologist's point of view, we've asked Professor Thibaut Demy, a cardiologist, member of the scientific committee of the Amyloidosis Alliance, about the red flags and tools available for diagnosis.
In terms of diagnosis, what is very clear now is the red flags that cardiologists can use. And these red flags are dyspnea, orthopnea, but also are also extracardiac red flags, which means that now we know that cardiologists have to ask to their patients if they have carpal tunnel syndromes, if they have lumbar spinal stenosis, if they have any trigger fingers. And now we have also reached a consensus to the cardiac imaging tools that we need to do to diagnose these patients. But they know that when they are suspecting cardiac amyloidosis, they need to prescribe the bone scintigraphy associated to the gamma-PATI testing. And with these two exams, they can discriminate the type of amyloidosis and go further. So we just have to continue to increase the awareness of cardiologists to make more and more diagnoses. For the tools, cardiologists now, we have reached a consensus to the tools to use to make the diagnosis. So of course, when they are at the office with their patient, they can do the electrocardiogram, the echocardiography, and with these two tools, the bone scintigraphy and the gamma-PATI testing, they can identify which type of amyloidosis has the patient and confirm, of course, the diagnosis.
Thank you very much, Thibaut. Does any of you want to add something on those red flags?
Yes, so Thibaut, as a cardiologist, talked to us about symptoms, cardiac symptoms, but there are some other symptoms that can be seen by a general practitioner, such as the edema of the lower limb or a weight loss. When you have edema of the lower limbs, it can be because of the heart, or it can be because of kidney insufficiency. And another point, and maybe Andoni will speak about it, is the little symptoms evocating neuropathy. I let Andoni speak about them.
Thank you, Sophie. Patients, they come to neurology because they present with tingles in the hands, in the feet, or anesthesia. They have abnormal feelings in feet and hand. And sometimes also they present with weakness in the hands and the feet. They have reduced capacities to do all those small gestures of daily life. So that's usually very prominent symptoms for patients from a neurologist's point of view.
Thank you very much, Andoni. Paul, you represent the UK ATTR Amyloidosis Patients Association. We know that there is a big challenge at the moment with addressing the disease. Could you tell us more about it?
Yes, I, as I said earlier, suffer from wild-type amyloidosis, so really in experience, that's all I can talk about. One of the biggest problems we have is GPs being aware of amyloidosis to begin the journey to diagnose it. I think really a lot of people are put on standard heart failure drugs with amyloidosis initially, and I've spoken to people that have taken 2 or 3 years to be diagnosed. So in the UK, we are putting forward an awareness campaign to doctors and hospitals and heart failure nurses about amyloidosis.
Thank you very much. Now let's see another small video and hear about some patient testimonies on amyloidosis.
After several years of going to many doctors, and no one could understand what was actually going on.
It took a relatively long time. It was about 5 years.
There was the right physician at the right place at the right time to put it all together, which saved me literally years of going through processes to find out what the diagnosis would be.
The issue is, if you don't live in the big cities, if you're not close to a specialist and you live in the remote areas of New Zealand, it is very difficult for you to meet clinicians or doctors that know about the disease.
Thank you to all of you for your testimonies. Let's hear now from the patient association's representatives. Maybe Catilina, you want to have some reaction on what has been said since the beginning of this roundtable?
Yes, just I would like to say that in this disease, when a disease is progressive, it is very important to have early diagnosis, and you have to be diagnosed in the first second to have a treatment and a good reaction to the treatment.
Jean-Christophe, do you want to say something?
Regarding the time in between symptoms and diagnosis, in my case, I was diagnosed 20 years ago, and it took 4 years. Nowadays, unfortunately, it's still close to 4 years to perform the diagnosis if we have a look to all type of disease. So we clearly need to go on our effort regarding awareness and to really reduce dramatically this time, this duration.
This is one of the biggest challenges that you have at the moment, right? Because it's a really long time. If the disease was treated from the beginning, you could prevent a lot of bad forms of it, maybe, or?
Absolutely, because with this disease, when there is some degradation, you cannot come back. It's there. That's why it's really critical to make the diagnosis as soon as possible.
Thank you very much. Barbara, maybe a word?
Yes, delay in diagnosis is really a problem for all types of amyloidosis. I think it's a bit shorter, the delay for AL amyloidosis, unfortunately, because otherwise it would be fatal for most of the patients. I mean, 4 years is far too long. And fortunately now, as we heard, there are red flags to diagnose a bit quicker. In my case, it took several months still. So the amyloid have actually the time to get stuck to the tissues of the organs and make damage.
Thank you. Vincent?
Yeah. That's a good point. Even today, and I've had amyloidosis while I've been in
the mic.
I've had amyloidosis for now, symptoms for about 15 years. But in my family, I was kind of lucky in a way, and not lucky, but the fact that my family have had it through several generations, and it affected my family. So my mother died of that. So I was automatically known about that I might have it, whereas other people present it out of the blue and they don't know. So that's very important. But I think early diagnosis, certainly in this day and age, is very important, because if you see that people are diagnosed early, and with the new drugs, of course, they're able to have virtually a normal life rather than waiting for the symptoms to appear.
Absolutely. Thank you very much. Is there any other reaction on this before we move to the next theme, to treatment and research? Of course, Julian, sorry.
I just wanted to say, from a medical perspective, it's a huge challenge diagnosing amyloid, because amyloid deposits can affect pretty much any organ in the body, and various different types of amyloid affect different organs, and some types of amyloid tend to affect specific organs. But ultimately, amyloidosis can manifest in pretty much any organ in the body, and so you can't say, patients with amyloidosis present in this way, and so you need to think of it at that point. The fact is that patients with amyloidosis can present in so many different ways with different disorder of different organs. And, for a doctor, it's usually not necessarily top of the list. If a patient presents with, for example, heart failure, they don't immediately think of amyloid because it's not the top cause of heart failure. But it needs to be always in the differential diagnosis, what medical people call the differential diagnosis. It needs to be in the back of the mind for, pretty much every way a patient can present in medicine, because, almost always amyloidosis is a possibility. And that's what makes it so challenging.
I have one thing that we didn't say, is that when a patient has lower limb edema, if the generalist or the practitioner performs a urinary stick, I don't know if it's the right term in English, but if you put a stick in the urine and if you see protein, it can be amyloidosis. Of course, it's not the first diagnosis, as Julian said, but it's one of the way to think of the disease.
Thank you, Sophie. I was wondering, as someone who's obviously not an expert, among the generalist doctors, how spread is the disease? Are you, of course, also raising awareness to them for them to know the disease, right? If I go to a doctor, and do most doctors know the disease, or?
Maybe I can answer what I know from French generalists. In the past, it was not taught in our medical school, so most of the elderly doctors, they don't really know. And then the youngest, maybe I will say my generation, it was taught in our medical school, so we knew about it because we had to study it and we had exams on it. So that's a way for the doctors to be sure to know the things. And now it's a little bit less taught, especially for the TTR wild type because of the heart failure. So it should be taught more.
And then?
Yeah, that's a huge challenge. And as a matter of fact, I was discussing yesterday with a general practitioner, and he was telling me that the patient we were discussing about was the first amyloidosis he was seeing in his life. And he was 60 years old. He told me, I've been seeing tens of thousands of patients, and that's the first amyloidosis I saw. So that's, from the GP perspective, it's quite rare. So it's difficult.
So it's another challenge.
Yeah.
Yes, Julian.
Yeah, I'm one of Sophie's old generation. When I trained in medicine, there was one line in my textbook about amyloidosis, and that was as much as we learned. And I completely agree with my colleagues that the awareness is improving. It's far from as good as it should be, but I think there is greater awareness now as there are more and more treatments. Doctors are more and more aware. They're taught about it more, and they're actually recognizing it and seeing it. So I think things have undoubtedly improved. There's a long way to go, as everyone's highlighted, but at the same time, I think the education around amyloid and the awareness is undoubtedly improving.
Thank you very much. Well, at least that's some good news here. Let's move now to treatments and research. Maybe we'll start with you, Sophie, if that's okay. What are the latest updates and medical research about this?
So maybe if I would say only one thing is there has been a lot of research on new treatments, and the most strikingly treatments are in TTR amyloidosis with stabilizer of the transthyretin tetramer and silencer of the transthyretin synthesis. So that's, and my colleague will speak about it, that's incredibly good treatments for those amyloidosis. And then in AL amyloidosis, the treatments from hematologic malignancy improve every year. So there are better and better treatments. And for example, in maybe 10 years ago, the treatments were not so good, and it improved from 30% to 80% of efficiency. And then in the rare disease that I'm responsible for, AA amyloidosis, which is inflammatory amyloidosis, we have better treatments for inflammatory conditions with anti-cytokine biotherapy. So we can reduce or decrease, or there may be no more inflammation. And also patient can get transplantation. So it improved a lot, and I would say in the research we are all looking for new treatments.
Thank you. Maybe.
Yeah, thank you. We had indeed massive breakthroughs in the treatment of amyloidosis, in the genetic form of amyloidosis. 10 years ago, we had almost only liver transplantation, and now we have several treatments that are quite effective, and there's a lot of research right now on other treatments, and Julian is involved in this kind of treatment with future treatments that are coming in the next few years. So that's really inspiring. That's really good news.
Thank you, Anthony. Caterina, you have maybe a question you want to ask about. I remind that you represent the Asociación Balear de la Enfermedad de Andrade, which is one of the, you're from Baleares.
Yes, I have a question for Sophie. What are the unmet needs for rare genetic amyloidosis?
So I guess you are speaking about lysozyme or apolipoprotein or gelzoline amyloidosis. And from my point of view, we have a lot to do in those amyloidosis because we don't have any treatment. So we would really need specific treatments such as the stabilizer of transthyretin, so the same kind of treatment or the silencer for those rare genetic diseases. But I don't know, maybe my colleague will tell me, maybe it's because they are more rare that there are not so much research. but we would really need that, and all my patients are claiming for treatments for their form of amyloidosis.
Yes, Julian.
Yeah, can I just say that all the treatments for amyloidosis at the moment, they are designed, if you like, to stop amyloid formation. So, they're designed to try and stop or slow the formation of amyloid by proteins in the body. And so, as Sophie was saying, for transthyretin amyloidosis, what we do is we either try and get rid of the transthyretin protein from the bloodstream with treatments that affect the gene and stop the production of the TTR protein, or we try and stabilize the TTR protein in the bloodstream so that it can't misfold and form amyloid. In a different type of amyloid, for example, AA amyloidosis, the protein that makes the amyloid is a protein called serum amyloid A protein. And what we do there is we try and treat the inflammatory disease to get the concentration of this SAA protein down in the bloodstream, because then you've got no protein to make more amyloid. And in AL amyloidosis, the protein is a protein known as a light chain. And again, what you do is you treat the underlying disease to get the light chain protein down in the bloodstream so that there's no protein available to make more amyloid. And in terms of the future, what I think that we are all hoping for is to have some treatments that accelerate the body's natural capacity to get rid of existing amyloid. So that we're attacking not only the production of new amyloid, trying to slow production of new amyloid, but also trying to, remove or accelerate the body's capacity to remove existing amyloid. And that at the moment is the holy grail that we're all looking for and hoping for in the next, hopefully, few years.
Thank you very much, Julian. Maybe, Vincent, you have a question also you would like to ask on that topic?
Yeah, hi, Julian. It's just the fact that with all these new drugs availability, and as I said, some countries haven't got it yet, but certainly in the UK, we have quite a few drugs being developed and being approved, hopefully. But ultimately, the game is to be able to give, or for the doctors to give patients several different types of drugs, maybe stabilizers versus gene silencing, so they have a combination of drugs to fight the disease. Is that the ultimate goal?
Absolutely. I mean, there are, as you know, Vince, if one thinks of cancer, for example, there are very few cancers that are treated with a single drug. And more often than not, most diseases are treated with a combination of drugs. And, that is no different in amyloidosis. One can imagine, for example, I'll give you an example. I mentioned that at the moment, we try and slow the production of amyloid. And in the case of TTR, transthyretin amyloidosis, as Sophie alluded to, you can either stabilize the protein or try and get rid of the protein from the bloodstream. So, the drugs that we have get rid of maybe 90% or 85% of the protein, but you still have some of that TTR protein left in your bloodstream. If you could give another drug to stabilize the remaining TTR, then you would have potentially no protein at all available to make more amyloid. If you then supplemented those drugs with a drug that gets rid of any existing amyloid more quickly, helps your body get rid of the existing amyloid in your body, then you're stopping production, you're getting rid of, you're accelerating removal. You can imagine that would be a very effective treatment. So ideally, I totally agree. It would be nice to have a group of drugs that we could potentially give to patients.
You were speaking about availability of treatment. Something I think is very important to notice is that in some countries, patients don't have access to those treatments because they are not available or they don't afford them. And that's a big problem, I think. And as there are very expensive treatments for some of them, we should work for that so that it's more available everywhere all over the world.
Absolutely, and that's, I think, part of today is to reach those regions of the world that we can help out, maybe in support and get that, because each country is different. Some are more political, some are more medical based. So I'm just saying that in the UK we're very lucky because our approval process is outside of government. But the ultimate game would be to help these other countries to try and at least get the drug availability for these people.
Yes.
Well, Jean-Christophe, maybe do you have a reaction on the first part on treatments and research? What do you think should be the most important thing at the moment?
Thank you. It's great to see all the progresses in the treatment for different forms of amyloidosis, but there are also several unmet needs for the patient. And for instance, there are some sources of transthyretin which are not affected by the drugs, the eyes, the brain. So the patient need, in some cases, to have some surgery to remove the deposit into the eyes. We see that when people were having a liver transplantation since, for instance, 15 years, they start to have some disorder in the brain. So those are some topics where we would like to push for some research. And there are also some needs regarding the quality of life of patients. For instance, many patients are suffering from gastrointestinal disorder, and that may ruin their daily life. So it's really important to launch some study in order to find solution to make this life more acceptable.
Thank you very much. Maybe Barbara, do you have what's in your opinion? What's the most important, like in terms of research? What do you think we should put efforts on?
Well, in terms of research, I think we already have lots of treatment lines now, but the good thing would be to push research on amyloid clearance, actually, for all sort of amyloidosis. And there are already some research work actually is already done, and some molecules might be approved soon, so that's a good thing to come up.
Thank you. Maybe Vincent and Paul, do you have also something you want to say on that?
Yeah, from a drug point of view, in UK, there are no drugs available off the shelf for wild-type amyloidosis. There's drug trials, but no actual drug that's been approved. So those of us with wild-type are waiting for approval. Tafamidis is not approved in UK, but virtually everywhere else in the world. So that's from my point of view.
Thank you. Katerina, Vincent, if you have...
I think that's it really, just to say that, like everybody, every country is slightly different, and the alliance here today, we're trying to make some of it equal between countries and help them to at least try and get some sort of drug availability. It's just potluck where you live, really, which is really bad.
Thank you. Well, let's see a small testimony videos on how is access to treatment all over the world.
Hi, my name is Tracy Deutsch.
My name is Fabio.
My name is Jamie.
My name's Paul.
Hi, I'm Sarah from Israel.
I'm from the United States, and I have good access to treatments for amyloidosis.
I'm from New Zealand, and there are no treatment options for us in the country.
I come from the UK, but unfortunately for wild-type amyloidosis, there is no approved treatment at the moment. I'm lucky enough to be on a drug trial.
In Israel, we get a very good access, and we're lucky.
In our country, we have access to some treatment, and I hope in the future we can have access to all treatments in Brazil.
Thank you very much, you all, for your testimonies. So, as we've seen, treatment is really diverse all over the world. Jean-Christophe, what do you think when you see all those testimonies?
Seeing so many differences between countries is really an injustice. There are some other areas where there is no treatment at all, like in South America and in Africa. As a patient, I'm really feeling outraged. There is also an important notion it's the price of the treatment for the patient. I am lucky enough to be French, so I have been received 3 generations of treatment without paying anything but taxes. And in some country like United States, you may need to mortgage your house to pay for the treatment. So we really need to work together, doctors, pharmaceutical company, and patient association, in order to reduce those differences.
Anthony, do you have a few words on this access to treatments?
Yeah, thank you. That's really a huge challenge, the problem of availability of treatments, a huge challenge for healthcare systems that are quite different between countries. And it puts forward a lot of problems of equity, of social justice, of taxes. You were saying that in France, we are quite spoiled. All treatments are available, but they are not free. We all pay taxes for this. We have a solidarity system, and everybody's paying for the few patients that can have the treatment. But the problem is huge, and I think the patients associations have a crucial role in there to put advocacy in the governments, in the healthcare systems, to try to have this treatment. So I think your role is quite really important.
Yes, as Jean-Christophe said, in North Africa, for example, they don't have availability. And for example, in inflammatory amyloidosis, we have very good anti-inflammatory treatments, especially in familial Mediterranean fever, which can be complicated by AA amyloidosis. And they don't have access. So I was in Algeria 10 days ago, and the nephrologist told me I have 400 patients with that amyloidosis, and I cannot treat them. So they are undergoing hemodialysis, and I can do nothing. So she was, as a doctor, she was desperate.
So what happens in this case if there's no way the patient can pay for it? Is there any alternative something, or is this, if you can't access the treatment, there's nothing you can do about it?
No. Some of them have a lot of money and they can travel and try to get some treatment abroad, but they have to pay for it. But otherwise, they are with the disease, which is progressing, because you can't get rid of the unfolded protein that will deposit.
And sometimes it's not just treatment that isn't available, it's also diagnosis. I was in Morocco a few months back, and they don't even have the genetic studies for TTR, so they are able to even have a diagnosis.
Tilena, maybe in Spain, can you tell us how, or Spain or in Baleares? I've heard there's a big, how do you say it?
Yes, in the case of the Balearic Island is an endemic zone. This means that we are a lot of patients, and now the situation is good regarding to the treatment, because now the treatments are available, but in our country it was a little bit different than in the rest of Europe, because when the drugs are approved in Europe, in Spain we had to wait for 2 years to have the treatments available for the patients.
Which is quite a long time, right? 2 years?
Yes, it is, because for us, for the patient, the time is crucial, because we cannot wait. We need the treatment at the moment of the diagnosis, and some patients had to wait.
Thank you all for your insights on the access to treatments. The next part of this roundtable is about the holistic approach, because as you know, the treatment might not be only enough. We want to know what is the quality of life of the patient as a whole. And we would like to welcome Laura Obici. Thank you for being with us. You're live from Italy.
Yes, good afternoon everyone, and thank you very much indeed for inviting me to join. I'm sorry I could not come in person, but really congratulations for this initiative.
Thank you very much for being with us. You're a consultant at the Amyloid Research and Treatment Center, a specialist in internal medicine. And we would like to know, we know that you're working on the holistic approach for amyloidosis. Can you tell us a bit more about it, please?
Yes, with pleasure. I think this is a very important topic that we are trying to encourage and to introduce in the amyloid community. Basically, by definition, holistic approach to care is an approach that addresses not only the physical needs, but also the emotional, the social, the spiritual needs of patients and also caregivers. We know that this group of diseases has a significant impact on relationship, family relationships, social relationships. So there are many additional issues and problems that are part of the daily life of patients and families. So an holistic approach to care aims at addressing emotional well-being, for example, also social support, considering the impact on professional life, and also spiritual needs. And we can say it's a more multidimensional approach to care, respective to a more biomedical, strictly biomedical approach that aims at being centered on patients and requires a multidisciplinary group of professionals in the health management that include not only physicians but also other important players like physiotherapists, psychologists, nurses, and the aim is to improve the patient healthcare professional group relationship and find more answers to the patient's need.
Barbara, you represent the French organization Association Française contre l'Amylose. Can you tell us, in your opinion, how the holistic approach can change a patient?
Yes, of course. I mean, Laura already told us most of the important things. I mean, the holistic approach is especially important in such a rare disease and multisystemic disease such as amyloidosis, because the patients have various organ involvement, and they might be a bit lost to face all those different physicians and different specialities. And sometimes the specialists only see their own specialty, and it's a bit of a tunnel view, a tunnel perspective, and the patient that doesn't really help the patient to cope with this disease impacting his whole life, as Laura told us already. So that's very interesting to have a holistic approach, I think, in that case, and seeing the patient as a whole person. It's an ideal situation. I mean, she told us about, because in reality it doesn't really work out like it, unfortunately. I mean, we have lots of patients complaining actually about the lack of or the absence of this holistic approach. That's a very good thing to work on that.
And so in a practical way, would you develop that? So what's the current situation? So you said,
I mean, a practical way, there are easy ways to improve things. I mean, especially take time to explain the condition to the patients, have shared decision making, and getting the patient to a better acceptance perhaps of the treatments too, and so have better outcome that way. And then to implicate other healthcare professionals such as psychologists and physiotherapists. I mean, that's a really good thing too. And perhaps provide support for the family and other caregivers, I mean, coping with the patient.
Yeah, hi there. We have been working as well on holistic care in the UK, but it's been very, very slow. And as like many people here, trying to get the medical profession to understand what's involved has been very difficult. But some of those top level things, which was said earlier, it's very good to have all those top levels like psychologists and everything. But they're on a more basic level for the day-to-day patient. There's other things which can be more beneficial, like, for instance, understanding what it's going to be like to live with amyloidosis, and have somebody like the patient organisation speak to them and tell them that this is what you can do on a daily basis to get you through each day. And it could be simple. It's like having support or knowing where to get, to look for availability of funding and stuff like that to help them. Simple things like blue badges for driving, simple day-to-day stuff, which makes a huge difference to quality of life. And I think that's one of the roles of a patient organisation, to get down to that bare essentials for each day.
Laura, do you want to react on what has been said?
Yeah, no, I agree absolutely with Barbara that this is still something that we have to work a lot on. But I think it's important to introduce the topic, to encourage a new approach. And to do this, there is also an ongoing international project to develop guidelines for implementing a more holistic approach to care. And we have promoted some recommendations as a group of healthcare professionals and patients from different patients associations across Europe. And we are now validating these recommendations that aim at implementing an holistic approach by suggesting specific points that can be targeted in daily practice across an international Delphi survey. And the initial results that we got are reassuring, because when physicians and patients were interviewed on the feasibility of these recommendations in practice, actually the idea is that not many of them are already implemented for the psychological, emotional, social aspects, but it could be possible to implement these based on present funding and organization. So I think it's a long way, but the community is now open to that, and probably some changes can be done even with the same resources and the same center organization. Of course, it's easier to implement these in large centers that are in charge of these diseases. But that would be already a very good first step.
Thank you, Laura. Jean-Christophe?
Yes, I have a comment for that. So it's a very interesting initiative. And having a national center in the different countries able to provide this holistic approach is really great. But I think the target to have in mind is really to have the possibility for all the patients to benefit from that. This means that also in the regional center, they should be able to deploy that. So maybe we need to be realistic and not too ambitious regarding the element to put in place, and especially the resources and means and the expenses associated, in order to really address the biggest number of patients possible.
Yeah, absolutely. And we need also to promote some research on that. For example, we are starting a project in which we aim at introducing also the possibility to have psychological support, not only in presence in the center, but also remotely. So this is something that requires investigation. We cannot say it's a practice that can be effective as in-person consultations, but it's worth trying to improve the role for telemedicine and telehealth also in this respect.
I was wondering, as a doctor, when you have a new patient, do you maybe address him to other healthcare professionals in that sense of the holistic approach, or how do you deal with this?
Yeah, of course, and our mandate as physicians is to treat patients, not disease. We have to take all aspects in view. And perhaps one aspect we didn't mention is the family aspect. I'm dealing with genetic amyloidosis, and when you announce some genetic diagnosis, you don't deal with the patient, you deal with all his family, because what you're saying to the patient, he will say it to his children, to his kindred, to everybody. So suddenly you are speaking to 12 people and not just one patient. So that's an important point also to take into consideration. And for this kind of problem, of course, we need psychologists. We need really an holistic view on all this.
Just only thing that I can add is for the patients with kidney involved in their amyloidosis, when the amyloidosis is in the kidney and they are undergoing hemodialysis. The hemodialysis is very pregnant in their lives because they usually have to spend their 3 afternoons every week. So in their daily life, the team of the hemodialysis center and the nurses and the people that will drive them there so many times a week will take an important place in their life. And usually they are totally in the hemodialysis center. They are like a big family. We were speaking about family, so that's something important too.
So Barbara, I was wondering, how does the patient coordinate? You know, there are so many meetings he should attend, or so many specialists he should see. How does it work?
Well, unfortunately, it's actually the patient who coordinates most of that, and it's very exhausting from the patient point of view to explain every time the same story to all those physicians, and so that could be improved actually. I mean, it depends on the type of amyloidosis. Ideally in AL amyloidosis, the patient sees mainly the hematologist because it's a hematological malignancy, not a malignancy, but it's treated like the myeloma. It's the same treatments, and then this a specialist actually coordinates most of the other meetings with the other physicians. But that's actually ideal too. It's not always happening. It depends on who is your practitioner. And so, yeah, that could be improved. In France, we are lucky enough to have some pluridisciplinary approach with the pluridisciplinary meetings actually taking place monthly or every 2 weeks, where healthcare professional physicians can discuss patient cases, complicated patient cases. So that's already something very interesting actually, and helping the patients too. But yes, ideally it would be better if a patient could coordinate that. Sometimes there are coordinating nurses taking over in some special referent centers. So that could be perhaps a good approach to help the patients to handle all that. Yeah, and as I said before, I mean this tunnel perspective of the specialist. Sometimes you have your hematologist is very happy because the light chains are down, so that's a sign of hematological remission in AL amyloidosis. But unfortunately, the organ damage can still progress, even if you are in remission otherwise from the treatments. So that's perhaps something important to understand from the most of the people too, because it's difficult to handle for the patients. It's a chronic disease actually. I mean, it's not over because you're in remission with the new treatments, unfortunately.
Laura, maybe?
Yes, I agree with everyone. I think probably the hereditary forms are particularly informative in terms of how many different specialists and the many different aspects of personal and family life that are impacted by the disease. I agree that the inheritance aspects also require to be dealt with care. And I would say also that one of the objectives of this process should be to build teams that collaborate together. And I think also the general practitioners where the health systems provide them should be included in this network. I think that could be extremely important. But I agree that in parallel with the organization, we also need information and more active communication skills from everyone as well.
Thank you very much, Laura. Let's move now to the last part of the last but not least. We've talked about the families, about the people who help the patients, so the caregivers, the organizations. Those people are dedicating sometimes their whole life to making the patient lives better. We would like to see a small video first, a full testimony of Vincent's wife, Lucinda.
I've always found it hard to see myself as a caregiver. I see myself as a wife, and this is my role, for better or for worse. My husband has hereditary amyloidosis. As far as a caregiver, there's lots of things that impact on me from just the effect of the amyloidosis on him. He's a different man from the man I married, and that's not a bad thing, but the amyloidosis affects his speed of walking. I'm quite a fast walker, so he's quite slow. He will rely on me for walking, so but I have to be careful that I'm not then, I've got a bad left knee, and I'm sure part of it is because it's always my right arm that he's holding on to, so I have to remember to swap sides sometimes to try and keep me safe. His word finding has increased over time. He gets more anxious, more frustrated. Again, none of these are a problem, it's just different. It's just a different life from how it used to be. It takes and I can completely understand. It took him a long time to realize he needed to stop work. I now am an artist. I work in watercolours, and that for me is my escape. And I have really good friends that I walk with, so that's also good. I can offload, and I would suggest find good people that you can talk to, that you trust. Be open and honest, because there's no point in not being open and honest, because the chances are we're all going through the same things, and there will be people who have already gone through that and might have some suggestions to help.
Well, thank you, Lucinda, for its very emotional testimony. Well, I'm going to start with you, obviously.
Yeah, I think, because I haven't seen that, so that's quite emotional, really. I think I was talking earlier about the fact that as a patient, we come to terms with our illness quicker than our caregivers or our families. And to a certain extent, you become to the fact that you're able to cope with it, and you become sometimes insular because you look after yourself, because that's what your body does. But for a caregiver, it takes longer, and it's a huge change, and that's what we found in our family. And also, coming to terms with it for the patient is a long time, but for the caregivers, their lives change completely as well. So certain things that you used to do, you can't do anymore, like heavy objects and moving. So the roles within a family can swap, But luckily I can still do cooking and stuff like that. But my wife still has to sometimes take the bins out, do things which I would have to do before. So it is a big struggle. And as she said, they have to have a relief outside of the family to support their own well-being, because that's very important for the caregiver, because otherwise they can become so embroiled in what they're doing and become ill themselves. So it's very important. But it's a long journey, and some families don't make it, a lot of them do. So it's very important to be upfront and honest, not just with your friends, but with your family, to say what you're going through. I have 2 daughters, and originally they said, when's Daddy going to die? Because according to them, we're going to die. So every so often I have to sit around the table and talk to them and say what's happening in my life and the new drugs availability, and the fact that I've done over 15 years. So, You know, it's very important that, and then I think caregivers take a lot on, and it's very difficult, and they need more support in some cases than the patients.
This is where associations can help. This is where they take place. Their role is there.
Yes, I think from the patient organization we can help the patients, the families and the caregivers. We can support them and we can offer different kind of services, resources and activities to help them. And I think it is very important listen to the caregiver because they have a lot of things to say and the caregivers are the people who is close to the patient all the time. And I think they have a very important role, and from the patient's organization we can help them.
In France, we publish a guide for them, which was written with the support of some caregivers, some doctors and psychologists, in order to give some advice, especially for the patient and the family who are discovering the diagnosis.
What about the UK association that you two represent?
We try and give out information on our website, but caregivers in general are never looked at, unfortunately, in my experience. I mean, my wife's been putting up with me for the last 7 years as a, not saying anything, but she does all the heavy lifting, as everybody has said. And you can multiply that many times, and they don't get recognition. It's interesting to hear we have a leaflet on it that might help caregivers, but they work very hard. And I agree with Vince that we come to terms with our problem, but caregivers in the main aren't talked about.
What's the perspective on doctors about this? Is it something you talk about with the patients?
Yes, of course, and that's crucial for the patient indeed, and caregivers need care also. But well, everything was said, and the video was quite emotional, and it was very nice. Thank you.
Thank you. Who would like to start? We would like to see what exactly is the role, what as an association you can bring.
In my opinion, I think the patient organizations have an important role for patients, families, caregivers, doctors, healthcare professionals, and also for the society in general, especially when we are talking about rare diseases. And in my experience, the patient organizations are a meeting point where patients can find a space where they can talk to other patients who are suffering from the same disease and to learn from each other. It is very important. And also the patient organizations are the voice of the patients, and its crucial mission is to defend and to fight the patient rights. Also, it is very important. And in summary, I would like to say that the patient organization can provide to patients, families, caregivers, resources, activities, accurate information, and different kinds of actions addressed to the needs of the patients and to improve the quality of life of the community. Also, from my point of view, I think that the patient organization can promote the research, and I think it is a good action because we need more research and the organization can push it. And finally, I think it is very important that the patient organization work with the doctors and the different healthcare professionals, because we need to work together, and also with the another stakeholders such as politicians, government, pharmaceutical company, because if we work together, we are stronger, and it is very important.
I was just going to really reiterate what Catalina was saying, really, about the importance of patient organisation. You know, we sit in between a lot of professionals, the authorities, and also the approval process. And we are the reason we're there because we can do an unbiased opinion on a lot of things, and also we can talk to all the drug companies, we can talk to the doctors, and we can have an unbiased opinion and treat them like that. But one of the most important things is to bring people together to talk about their disease. And one of the most powerful things, you know, we try to do road shows and things like that to get people together. But we found the important thing and the most thing they like is just to get together on Zoom or something and just talk about their daily lives, what impact and how they deal with certain things in their lives. And that seems, you know, having a psychologist do that is slightly different, but having that is similar, and it makes a huge difference to just to say that someone out there has got similar problems, and that's really helps them get through the day, really.
What's the As Vincent talked about, what's the relationship between doctors and associations? Is there some kind of link? How do you work together?
I will take the example of the French Association of Patients Against Amyloidosis. This association is active since many years and is doing a lot of work to link us to the other amyloidosis center, because they are dealing with all the types of amyloidosis, so that we can meet and we can work together and, as you said, be stronger. And also they help us to find a way to organize a therapeutic education and to plan some research. They support us and they help us to organize meetings, so they are very helpful. And without this association, maybe I can speak from my point of view, I would not have done so many things for amyloidosis, because we don't have enough time and energy, and with them we do much more and better.
Laura?
Yes. No, I agree with everyone, and I wish to echo Catalina's comments on the role of association in research. I think this is a very important point. I think in the future this should be increased as much as possible, both for non-sponsor investigations and for clinical trials. I think patients, and this is something is already going on for many other diseases, also with regulatory agency, patients should be absolutely represented in order to contribute to the design of clinical trial, to the collection of samples. There are many aspects in which patients should have been involved. And I also know, for example, I've been recently in Finland, where there is a very important association on Gelsonine amyloidosis, and they have really contributed significantly to design a registry, to collect information, to define the natural history of the disease together with the physician. So really, I think in these rare diseases, and particular amyloidosis, are a model for further investigating many aspects in collaboration with the patients and physicians.
Last word on this topic from Christophe.
I just want to share a few words about the Amyloidosis Alliance. So this is a kind of umbrella organization whose objective is to support the patient organization in the world, to share some best practices, some good achievement among the organization, to also target the main challenges and help all organizations at international level. And we talk about that before. It's not an easy task. It's to help also the country in the process for drug approval. And this is a long journey, but we hope that we can help some country for that.
And one more thing, I see Laura Obici here on the screen, and thanks to the Alliance, we are here today. We are not in the same country, and we can work together. The practitioner can work together, and we are not each in our country trying to do our stuff. So we can be more efficient and for the patients.
Well, thank you all for your insights on this part. And we would like now, before we end this roundtable, hear a few words from the new president of the ISA, the International Society of Amyloidosis, Professor Stefan Schönland.
Thank you for inviting me to this very interesting and helpful roundtable discussion on amyloidosis on the World Amyloid Day with patients, their caregivers, and treating physicians. This important meeting will increase the awareness of the amyloid diseases worldwide. My name is Stefan Schönland, and as you already mentioned, I'm the current president of the International Amyloidosis Society, called ISA. I'm working in the Heidelberg Amyloid Center in Germany as a specialist for hemato-oncology and internal medicine. Our society, ISA, has a long history bringing together physicians and basic researchers from all over the world to improve and facilitate research to improve our understanding of this diseases, to improve early diagnosis and other treatment modalities. In this roundtable, you already mentioned that there was a huge progress in the last years for the treatment of ATTR, AL, and AA amyloidosis. And on the website of the Amyloidosis Alliance, you can find a nice summary of the scientific results of the last international meeting held in Heidelberg in September this year. But even more important, it was the first time since the COVID pandemic that more than 800 amyloid experts from all around the world could meet each other and exchange their ideas on a personal basis to strengthen relationships and scientific networks. Hopefully, this will again impact research in the near future. The agenda of the new ISA board, with members from North and South America, Europe and Japan, will focus on publishing guidelines of various topics, now also trying to include the perspectives from Latin America and Africa. And as we have heard today, how important it is to bring together patient organizations with researchers and physicians, the board will approach the Alliance and discuss how to improve our collaboration in the next 2 years. Finally, we will organize smaller amyloid meetings in 2003, but of course our focus goes already on the next ISA meeting, which will be held in Rochester, Minnesota, USA at the end of May 2024. Thank you again to the organizers for including me as a representative of ISA in this roundtable today, and I'm looking forward to meet and discuss with you in the near future how ISA and the Alliance can intensify their collaboration. Thank you.
Well, many thanks to all of you for being here. I know some of you came from afar, and thank you for participating, for your insights. And Jean-Christophe would like you to say some words to finish this session.
Thank you, everybody. This was amazing to have such a panel of doctors and representative of patients. I think we gave a good view of the disease for all the general public for this World Amyloidosis Day. And I say to next year for the new session.
Thank you very much, and thank you very much, Agnès Farrugia, for your amazing work. She's here with us. Thank you to her for this. And thank you very much to all of you here for your attention. And don't forget to spread the information around you about this rare disease, because the world needs amyloidosis to be known better. If you or any members of your family is having the symptoms we've described, please talk to your doctors. As we talked about, it makes a difference to have an early diagnosis, as treatments are already available and research is always ongoing. Don't forget that organizations are deeply involved and are on your side as a patient, as a caregiver, to give you information, to help raise awareness, as we did today for the public, but also with doctors and with authorities. You're more than welcome to join these organizations or to donate to support the amazing job they are doing. But before we come to an end today, I'd like to thank all our partners for their faithful support. Amyloidosis is a small community where all the stakeholders, patient organizations, healthcare professionals Researchers and pharmaceutical companies are strongly committed to improve amyloidosis patients' condition. And we would like to thank particularly Alnilam, Alexion, AstraZeneca, BioBridge, Intelia, Ionis, Janssen, Pfizer, and Sobi. Many thanks as well to all the members of our scientific committee for their commitment despite their very busy agenda. They always take time to work with the Amyloidosis Alliance to raise awareness on the disease, to educate the medical community on amyloidosis diagnosis and treatment, and to treat and support amyloidosis patients. Ladies and gentlemen, thank you again and see you next year for the Amyloidosis Day.